Good morning. My name is Alexandra Corner. I'm a nursing student at the University of Regina with collaboration with Saskatchewan Polytech. Currently, I am in CNUR 209, which is a research course, and I've conducted a literature review and created a research poster on the topic that I have researched this semester. So I'm just going to share my screen and go ahead with my presentation. All right. So hopefully everybody can see my screen okay. Um, so this is my poster. Um, and I'm just going to zoom in during my presentation just so that you guys can kind of see the text in full effect, because if you're not sitting right in front of the poster, it's probably a little bit difficult to read. Okay, so my topic was on nosocomial infections and method of delivery. So my research question was, in postpartum women up to 30 days after delivery at the Regina General Hospital, how does the incidence of nosocomial infections in vaginal delivery compare to the incidence of nosocomial infections in women who have had a cesarean section? And we're hoping to conduct this research over 2 years. And this is just to get more accurate statistics and results. So I'm just going to zoom in on the introduction section. That's where we'll begin. So I'm just going to kind of give you guys a general background of kind of some terminology and why this research is important. So childbirth is a very significant event in a woman's life. It's often accompanied by physical, psychological, social, and financial changes. It's a very large change in a woman's life. The process of childbirth, whether it's via cesarean section or vaginal delivery, poses risks to the mother's well-being and health. A statistic from the SHA that was published in 2025 stated that 97.5% of mothers give birth in a hospital setting, whether it's vaginal delivery or cesarean section. So that's a very large portion of the population utilizing hospitals for birth. So just comparing and contrasting the difference between vaginal birth. So vaginal birth or natural delivery, natural birth, whatever you'd like to call it, involves the baby passing through the birth canal with the aid of contractions and mother's effort of pushing to deliver an infant. So as you can see from the image up above here, this is what we would consider a vaginal delivery. Whereas in comparison, we have a cesarean section or a C-section. This is surgical birth. So it involves a doctor or surgeon making incisions into the mother's abdomen or uterus to deliver an infant. This is often, well, this is always done in the OR, and it's definitely a more higher risk than a vaginal delivery, but we do it in an emergent situation or electively, or if the baby is anatomically or the mother is anatomically not able to have a vaginal delivery. So hospital births are generally considered to be safe, but they're not without risk. Every time we enter a hospital, there is a risk for us to acquire a nosocomial infection, whether we're giving birth or not, if we're just visiting somebody. Um, Nosocomial infections are what we consider to be hospital-acquired infections. So these are things like MRSA, C. difficile. They're infections that we get when we're getting treatment in the hospital. Some people get pneumonia when they're in the hospital as well. And these pose a significant risk to anybody who gets them because they're often very, very tough to treat for us because they're grown in the hospital. So there's limited data that exists on the incidence of nosocomial infections based on method of delivery. So my research was hoping to explore if there's a significant difference between if a woman has a vaginal delivery versus a cesarean section, whether or not that one is more at risk than the other for acquiring a nosocomial infection. So essentially, just to reiterate what I said, So the objective of my study is to compare the incidence of nosocomial infections in postpartum women based on method of delivery in order to inform best practices and support evidence-based policy guidelines that will help improve patient outcomes. So essentially, I wanted to explore are cesarean sections or vaginal deliveries more likely, who's more likely between the two to get a nosocomial infection so that we can implement some better policy to help these moms with that transition into postpartum. So, how did I conduct my literature review? So, that's my methodology. So, I'll just pull that up here. Um, so I conducted a literature review to explore my research question. It was a really in-depth review that I did. I focus only on peer-reviewed studies, and that's just because of the validity of a peer-reviewed study. It's significantly better than a non-peer-reviewed study. And I focused on infection risk associated with method of delivery, of course. So I used a couple databases. One that you guys might be unfamiliar with is the University of Regina database. So my university specifically provides us with its own database that you can search terms and then it pulls from every database. So I started there and then I refined some searches because not everything's available to them. So I also used PubMed, um, CINHL, and Cochrane Library. And the filters that I utilized was peer-reviewed, available in English, published after 2007, and after 15 years. I also did remove these date studies, and I'll just talk about that a little bit later. Um, some search terms that I use, there's lots of synonyms, as you can see by when I was defining terms. So nosocomial infections or hospital-acquired infections, vaginal delivery or natural delivery, cesarean section or C-section. There's also another spelling of cesarean section, so I also utilize that. Incidence or prevalence and postpartum. So I included some sample search terms. You're more than likely or more than welcome to have a look at these, have a read over them, try and punch them into one of these databases because you'll probably be able to yield a lot of the same results that I got. And that's just why I included these. So I'm just going to circle back to what I said about the times and publishing after 2007 or 15 years. So after I had received like a plethora of data, I noticed that a lot of them were citing a work from 2001. Pretty well every article that I pulled used this article as a citation. So I went and I looked at this article and was perplexed with just the amount of rich data that it provided. So I also chose to use this article written by Yoko and her research team. It was written in 2001, but the data to this day is still considered to be relevant. So that's why I can continue to use it. So this is my Prisma flow diagram. So I won't bore you with all of the details, but as you can see, after I went through all of my databases, I got 57 articles. I went through a little bit of a screening process to end up with the five. I just want to touch on the inclusion exclusion criteria that I used once I kind of received like 15 articles. So um, one of them being I the abstract was in English, but then when I pulled an article up, it was in a language that I could not read. Um, there was actually quite a few articles that were based on like rare diseases that were case studies that aren't really generalizable to the public, but they were really interesting to read. But I didn't put them in my study. Um, and then the article was on like a very refined postpartum uh, population, so mothers with diabetes or mothers with MS. Like, so although they're interesting and valid in their own way, not applicable and generalizable like I wanted them to be. And then um, it was on like surgical infections rather than a nosocomial infection. So I wasn't able to apply the incidence of surgical infections in my study because women that give birth vaginally aren't going to acquire a surgical infection. And then some of the articles weren't representative of Regina General Hospital as a whole. So, Regina General Hospital is the hospital that I hope to study. So, it's considered to be a like tier 3 hospital. Um, so, it's got specific units and all that, but it's not really comparable to, say, a very high tier 4, tier 5 hospital in Toronto. So I tried to keep it to rural hospitals that sometimes they require assistance from other hospitals as well. Like Regina often utilizes Edmonton's hospital for help when situations are a little bit more severe. So yeah, that's my Prisma flow diagram. I'm sure that if you guys used the search terms that I used, you'd be able to recreate this diagram here and see my exclusion inclusion criteria. So my results and findings. So of the 57 studies identified, 5 were selected for analysis. All of the articles were peer-reviewed and within the search criteria, with the exception of the article written by Yoko. And that's because it was included for its continued relevance, still being referenced to this day. It hasn't been disputed. So therefore, I decided to use it as well. So all the articles actually consistently showed the same results. All of them showed that there was a higher incidence of nosocomial infections following a cesarean section when compared to vaginal births. So this 2024 study developed a nomograph, which identified cesarean section being the second highest risk factor for postpartum nosocomial infections. I actually included their uh, nomograph in my analysis, so I'll be able to show that to you guys. Um, so these two articles here, sorry, I'm gonna butcher the last names if I say them, should they showed evidence to support cesarean sections being a risk for infection when compared to vaginal delivery. And then Leff found that infection rates among C-section patients were 7.6%, whereas with vaginal deliveries, they were 1.6%. So that's actually a very big difference between the two. So as you can see, our results from this literature review are showing us that C-sections put you more at risk for nosocomial infections than vaginal delivery. So I'll just go into my analysis section here. So this is a nomograph created by Huang. So it was actually done in an area in China, but when I researched their hospital, it was comparable to RGH. Um, so this nomograph represents factors that contribute to postpartum nosocomial infections, and cesarean sections are the second highest, with increasing probability by 30%. Whereas when vaginal delivery is considered, it scored less than 5% increase for risk of infection. So if you actually look at the nomograph, it's right here. The only other things that kind of put it high, like that were higher than a cesarean section, were other medical interventions. So this would be like central catheter or even a urinary catheter. That also puts people at risk for infection, but I'm sure we all know that. So in nursing practice, this guides the need for infection control following cesarean section. Um, it also kind of encourages us to want to reduce hospital stays, because the longer you're in the hospital, the more likely you are to acquire one of these infections. And then early identification of infection is really, really important as well. So checking that temp all the time, checking surgical sites, and just checking in with the patient on how they're feeling. That's super important as well. So in conclusion, after conducting this literature review, it provides strong evidence indicating that mothers who deliver via cesarean section are at higher risk than those who delivered vaginally. So there's level 1 and level 2 evidence that support this conclusion, and this strengthens the validity and reliability of the statement that I'm saying. So, given the risk associated with cesarean sections, nurses must prioritize infection control strategies, prioritize early detection. So, as I said before, taking temperature, making sure that they're monitoring how the moms are feeling, checking infection sites, checking level of consciousness, and then doing like really diligent post-operative monitoring for those moms who have had cesarean sections. So policies also should reflect this evidence to guide for best practices and patient safety. So not only does this apply to nurses, but this applies to policymakers. And when the nurses and the policymakers get this information, it then can be transferred to the public as a whole. Um, so then moms can make more of an informed decision on whether vaginal or cesarean section is best for them. I know that sometimes it's a non-negotiable, especially in an emergency situation, but elective cesarean sections are becoming more common, and risk for infection is something that we do need to consider. So future research should include larger scale studies. It should consider the qualitative or mixed methods just to enhance that generalizability and transferability. So, as a whole, as a learning nurse, I think that this research really opened my eyes to the importance of infection control throughout the whole hospital and just the steps that we need to take in order to make sure that everyone's having the safest stay when they're in the hospital. Okay, so I'm just gonna turn it over to a Q&A. So I had a couple questions asked that I'm required to present about. So I'm just gonna go ahead and do that. I just have them on my iPad here. So the first question is, given that most of the studies in the review utilize observational designs, what are key threats to internal validity inherent in observational studies in this context, and how might they be affected? How might they affect the results? Furthermore, considering the specific research question regarding the comparative risk of nosocomial infections between vaginal birth and cesarean sections, could a randomized control trial be ethic or practically feasible, and how would this alter the evidence? So I understand, and I said this in my critical analysis, that having just observational studies was quite problematic. Um, they researchers like can't control the group allocation, um, and they can't control who's going to have a vaginal delivery and who's going to have a cesarean section. And this may cause some selection bias. And we also just have to consider the fact that people who undergo a cesarean section are probably already more at risk and therefore might acquire infections easier as it is. So that's kind of something to consider. Information bias, data and medical records um, might be incomplete or inconsistently recorded. All of these studies, they used surveying of medical records. Um, we as like nursing students know that sometimes the chart doesn't have everything in it. So surveying medical records without follow-up is a problem. All of these research studies, that was a huge flaw about them when I did the cohort study checklist from JBI, is the fact that um, they're they didn't do any follow-up in the medical records to see if maybe this person had a false positive for an infection or it was something other than a nosocomial infection, and we just assumed it was. So a lot of the studies attempted to look at confounding variables, but sometimes there's confounding variables associated between delivery type and infection risk. So I had kind of said that before. Um, so essentially, it would be more ideal if they could do more than just an observational study, but unfortunately, there are ethical concerns when it comes to doing an RCT on this study specifically. Um, we can't say you get a C-section, you get a vaginal delivery, you get a C. Like that's not ethical at all because we often are doing C-sections out of the safety of the mother and of the baby. Um, so unfortunately, that's not something that we can really explore. Um, an RCT obviously would offer stronger validity through the control of randomization and all that good stuff, but we just need to continue with these well-designed prospective cohort studies. Um, yeah, so that's my question about internal validity. So then I had a question about generalizability and external validity. So several studies cited in the review were conducted with specific hospital districts, potentially limiting the generalizability of other settings, including the general hospital. In light of this, how might lack of diversity in hospital settings impact the external validity of the findings? What specific strategies could future research implement to enhance the generalizability of their findings to broader populations of postpartum women? Um, yeah, so this was like a big one that I found really difficult. So I kind of had to do a little bit of digging on my own to figure out what kind of hospital the general hospital was and what kind of hospital the hospitals that the articles were on was about. So things that we need to consider when we're considering generalizability with hospitals is the actual infrastructure of the hospital, protocols, procedures, policies that are actually followed in the hospital, staff training, the demographic of the population that's utilizing this hospital as well. Um, so the general hospital is a tertiary hospital, but in itself, it has many issues as well. It's in a low-income neighborhood. It's very old and often it's strict infection control can't really be followed because of the way that the hospital is laid out. Like a lot of the rooms don't have a proper isolation galley or anything like that. So it's really hard to create this study and make it generalizable, especially when the terminology that we're using that applies to our hospital isn't exactly being used overseas. I had yet to find a Canadian study, which I found really troublesome. So I tried my best to find studies on societies that kind of mimic Saskatchewan, but this is kind of a rare place. Um, so to enhance generalizability, we want to do some multi-site studies. So this would include like, we're going to study this urban and this rural and this high and low resource areas. So kind of do it on a national scale rather than, for example, one of the studies was on this tertiary hospital in Denmark between this time and this time. Um, so yeah, doing like a larger, broader scale study would help with generalizability. Okay, so data and interpretation and confounding variables. So the studies mentioned do not account for potential confounding variables that might influence the risk of nosocomial infections, such as differences of socioeconomic status, healthcare access, and comorbidities. How could these variables be systematically controlled in future research to ensure that observed differences in infection rates are truly attributable to the method of delivery, and what types of statistical analyses or research designs might mitigate the impact of these confounders? So one of the studies that I did have, the one that was published in 2024 in China, did mention some confounding factors. Um, I personally don't think that it was enough. They really explored BMI, diabetes, um, but they didn't delve into that socioeconomic side of things. Um, so we would want to kind of do like design level approaches with that. So using prospective cohort studies with baseline data collection on confounders. Sorry, I have a cold, so if I'm sniffling a lot, I apologize. Um, and then just ensuring that we know all of these confounders about our patients because a confounder can skew your data completely. Um, and then just using matching techniques as well when we're doing analysis. So making sure that we're comparing correctly. And then using multi-variable regression models. So adjust for age, BMI, comorbidities, and all that. And then really and analyzing those subgroups. Just because we know that like this can all cause causal interference, which is really, really problematic. Excuse me. So missing research methodologies and conceptual gaps. Yeah. So the review highlights that no qualitative or mixed method studies were included in the analysis. What are the potential advantages of incorporating qualitative approach? So interviews or focus groups with postpartum women in understanding the experience of nosocomial infections. How might such an appropriate approach, contribute to identifying new causal factors or interventions that quantitative studies might overlook? What specific research questions would be more appropriate for qualitative exploration in this context? Okay, so qualitative methods in this would be so beneficial. And I only say that because, like, giving birth is a lived experience. Every mother that you talk to, their experience is different. So just looking at the numbers and looking at the medical charts, we're not getting a full picture of what these moms are experiencing, what their perception of the care is, what the barriers of proper hygiene practices were post-delivery. They can reveal issues that we as researchers might not be able to see. So this might be understaffing, poor communication, um, or just like or hospital conditions, right? Um, so we might be able to identify unmeasured causal factors as well. So that would be really awesome because the quantitative study doesn't really give us causal factors. It just kind of, we look at it and we're like, well, yeah, this is happening to people with cesarean sections, but why is it happening? So we might be able to generate more of a concrete hypothesis based on causation. Um, and then once again, we want to focus on patient-centered interventions. So this might move us into being able to use patient-centered interventions as well. Um, so uh, I came up with a couple qualitative questions. I'll just read you off two. So, what challenges do families face in maintaining personal hygiene post-delivery in hospital settings? So, this is like a really good question to ask, and one that comes to the top of my head is not everybody has access to even a bath or a shower when they're in the hospital based on how the hospital's laid out. Um, so then we could also ask about like prevention measures. So how did you as a mother after giving birth perceive infection prevention strategies in the hospital? So did they look good? Did they not look good? Did you not care? Like, because not only are we talking about infection with the mom, but like, what about that little baby as well, right? So this can open doors to a lot more research on the mother baby units. So then this is also a question that I kind of glossed over in my presentation, but I'll just talk about it again. So the review includes one secondary research article by Yoko. So that was actually a primary research article. It wasn't a secondary. Um, it was published in 2001, and I justified including this due to the article's seminal nature in informing more research studies. Critically evaluate this decision. What are the risks associated with including older studies that may no longer reflect current principle or clinical practices, infection protocols, and population characteristics? And how might this impact the overall relevance and rigor of the literature review's conclusion? And what other criteria could be used to justify the inclusion of older studies? Excuse me. So I understand that it was a big gamble putting in a study from 2001. As you can see, like 57 articles isn't really a lot when you're searching the entire universe of peer-reviewed articles. And a lot of them didn't really apply. So just bear with me a little bit with that. But the risk for including an older study, it's there. It might not include our current clinical guidelines. Like what has happened in the last 5 years that has changed our clinical guidelines so much? Like think about COVID-19. That's a huge piece that guides what we're doing in the hospital. Surgical techniques have changed. The amount of cesarean sections that are happening since then have changed. It's a lot more normalized now than it used to be. And infection control measures in general are just so different. And nursing as a career and what we do as nurses is so different than in 2001. Like that was a long time ago. Like I was 2 years old in 2001. There was no cell phone, there was no nursing central. So I think there was like definitely a lot of things that we weren't even aware of back then. Nosocomial infections weren't as common back then or as educated about back then. Um, so we just have to think about the changes in patient demographic. So moms are older now, antibiotic stewardship. So that's a big contributing factor to nosocomial infections and who's more um, at risk. And then I already outlined cesarean protocols. That's just completely different than what it used to be. Um, so this can have an impact on my conclusions because it really reduces the relevance and the applicability of my findings. Um, and it can skew the data. Um, I definitely do believe this, but based on the fact that all of my studies pointed towards the same conclusion, I still think that they were reliable and applicable. Um, my justification, other than what I've already said for including an article from 2001, is um, they create a foundational theory or methodology that's or like often still used today. So like my reasoning behind this is based on seminal value, which is other articles are still citing this and people are still revisiting this information. So it has to have some sort of validity because people aren't trying to dispute it. Um, they supplement current studies And we can use it as a compare and contrast. And when we do compare and contrast based on the data that we've received today, um, it's still pretty in line with this 2001 study. And then um, we can use really rigorous analysis in a systematic review to ensure that we're making the proper conclusions. Okay, so that's all the questions that I had asked for me. Um, so yeah, I had a lot of fun doing this research and creating this poster, and I hope that maybe one day um, policies in labor and delivery and all that make it so that moms don't acquire hospital acquired infections at all. That would be so cool. Okay, thank you.